Shall we wait for some time or? नहीं, echo अडिक्किदु. Echo अडिक्किदु. Echo अडिक्किदु.
Hello, testing, check.
Hello. Hello. What's that? So, good afternoon, everyone, and warm welcome for the class on thyroid functions. And I won't be talking on hypothyroidism. I'll be talking an interpretation of thyroid test and if time permits, we will subsequently go into the subclinical hyperthyroidism and hyperthyroidism treatment, probably an overview, because most of the time it's the diagnosis which actually makes everything complicated, because there may be an even there you may be starting on antithyroid drugs where it is not mandated, or maybe starting on thyroxine in a patient where you really need not start on and you can keep on following. Right. So, but briefly, maybe in 3-4 minutes, I'll just start why this complexity of thyroid hormones, where you have a TSH which secreted from the pituitary or much higher than the TRH comes from the hypothalamus, then comes to the thyroid functions, thyroid gland, and then T4 produces, then T4 goes to the T3, get and activated and get have their own functions in various tissues. But remember that even before that, there are a lot of multiple steps. I'm not going to the detail of this because this is much looks simple, but there are multiple complicated way there. The mitochondria get activated, Golgi bodies come into the picture, and finally the thyroid hormone is produced. So it looks simple that you have a feedback mechanism from all the way from hypothalamus, pituitary, thyroid axis. So it's called hypothalamic pituitary, pituitary thyroid axis, where it actually gives us various permutation combinations where you have a hypothyroidism, you have TSH raised, and you hyperthyroidism where the TSH suppressed. So basically, it's a feedback mechanism which is called negative feedback, where means one gets lower down, other gets higher. So it's reciprocal. So I am not going to detail of this secretion, but remember that the T3 is a activated hormone in the periphery, which actually has their functions in various tissues. And also need to understand T3 is secreted in a, or maybe in other words, produced in a very micro quantity. So if you want to do, suppose if I have an 1 kg way of basket here, and if there is 10 grams lesser, it's much small. You say the 10 gram is lower, but here what we are talking, it is picogram or microgram or nanogram. So that means even a slight deviation in the laboratory will cause a major shift. That means 1 meter is not equal to one micrometer. So it is major difference. So you need to understand that all the hormones which are you are doing in your lab is in the micro, nano, or pico. So you have, your lab should be having a very good sensitivity to pick it up at a lower level. That is why T3 all over India is not a great test to do, because it's much smaller. So then T3 should be reserved for very, very limited. So you are kid first thing, remember that T4 is important, TSH is important. If you have a free T4, that's enough. Free T3 and T3 should be reserved only for limited areas. So in your prescription or in a laboratory investigation, T3 shouldn't come actually. It's not really going to change. But on top of it, it also understand that once a T4 or T3 is produced and are secreted from the thyroid gland, someone takes that to the periphery for an action. That means an albumin or an thyroid binding globulin all needs to be there to pick the thyroid hormone and take it to the periphery and do the action. So that means you have another mediator which actually takes that and to go to the periphery. So that alone also that can be a changes. So but remember that all this other than hyper and probably subclinical hyper and probably other we are going to discuss, this all are very smaller quantity. Let's say 1 in 1 lakh or 1 in 2 lakhs or maybe 1 in 1 million, all this. If you look at say MCT8 mutation, don't look at for in every patient. You will be seeing 1 lakh of hypothyroidism, you get one patient. Or if you are sitting in a pediatric endocrine OPD, you might get it one, right? So further down, when the albumin or a thyroid gland takes the thyroid from the thyroid gland to the periphery, the thyroid gland hormones has to enter the cell and make the changes in the protein. for that the function happens. So though there is much more finer functions happen beneath. So there can be a problem at that level. Again, these all are rare diseases. So you won't see actually a common disease in the population which you can see in our clinical practice, because this all are predominantly a pediatric problem, because they don't grow or they have a severe stunting or could be having a mental retardation in the as a fetal and then subsequently have their problem. So but these two happens in, you know, in the adult population, but in a very smaller quantity. So again, this again you won't see. But why I am talking about all these things is, whenever you see a thyroid functions, you may get it. So that time you shouldn't miss it. Okay, fine. This again is a, in nutshell, what are we going to talk is revolves around this. If there is less thyroid hormones, the thyroid TSH, that means thyroid stimulating hormone in the pituitary, goes up. So if there is higher functions in the thyroid gland, then the TSH suppressed. So this is all revolve around this, but we will go into probably, I'll just, sorry. So this is the commonest way we diagnose. Like, I mean, if you look at hypothyroidism, classically you have high TSH and low T3, or let's say T4, ideally T3 in a, let's note, take it to the picture here. And if there is subclinical hypo, that's mean balance, that you have a like slightly, let's say 10 million international unit of TSH, but T4, FT4 may be normal. So in the inappropriate is the other extreme, where you have a mix of hormone, like mix of finding, when TSH may be low, T4 may be low, free T4 may be low. What exactly is that? We will come to this. So that is main. But the discordancy happens when you see this. That means you have a normal TSH with high thyroxine. It's a discordancy. What exactly is discordant? It's not exactly what you see in your garden variety of hypothyroidism or hypothyroid. High TSH but high thyroxine. Again, if you have a high TSH, you should have a normal or low thyroxine. Okay, and suppressed TSH, you expect the thyroxine to be high. That's hyperthyroidism, but you have everything low, right? And you have a normal TSH but low thyroxine as well. I mean, that means the TSH is absolutely normal when you look at the finding, where clinically absolutely asymptomatic, but you are finding a low TSH, T4 level. Okay, fine. I think from here we are not going to discuss. I'm not going to talk here. I'm going to ask questions, right? This is a yeah, lady, where you can see that patient had a COVID. Let's say it's a viral infections, not necessarily COVID, but because COVID was there in our past. So patient has come to with and yeah, with a recent weight loss, but absolutely it's stable. Glucose levels are normal. So for easy understanding, I thought TSH was suppressed. This is probably cat on the wall, high, low, normal, and this is low. What exactly is this? Pardon? Sick thyroid, but the patient is mild ARDS, not in the ventilator. So sick thyroid, remember that predominantly sick thyroid when they're really sick. Patient is not sick, I recovered. And patient had a recent weight loss. Pardon? Sorry? Louder. It's okay. I can never be your examiner because university never allows me unless your boss allows me. Pardon? Viral thyroid. Yeah, you got a viral, you got a hyperthyroidism, then probably it's not investigated. Then why it is all suppressed? There is a discordant. If you have a 0.02, you should have a T4 high. Pardon? Resolving, yeah, it's resolving. So, but if you really want to prove it, then you have to do an uptake study. But clinically, so what will happen is you shouldn't start on thyroxine by looking at this. Ask the history. This, if you ask a little more history, there may be some pain in the neck, could be a weight loss where there may be a tremors, palpitation. So ask for a simple more history and don't start on thyroxine, because this is a classical subacute thyroiditis. Because for the differentiation, you can see that in toxic goiter, that means autonomously or endogenously producing thyroid, then you get a high uptake. But in CMC, you can prove it. But if you're working in a remote setup, you can always go with your clinical finding and just leave the patient off, and then there'll be normal. So this is the classical way they go. When there is a set of viral infection happens, it could be any viral, it could be even common cold also. They'll have a hyperthyroid phase, then they go to euthyroid, then they go to hypothyroid phase and then become normal. Unless there is a destruction of the thyroid happen, then they'll become hypothyroid continuously, right? That's very important. In this phase where you have a T4 low, then TSH is high, you might need to start on that. That's why you must be seeing a lot of patients where you start with thyroxine and after some time you don't need any thyroxine. You may be wondering why they become hyperthyroid. And one of the common thing is which is subclinical viral infection sets in, especially during seasonal time, or maybe having, there are people say that because of some endogenous epitope or whatever, it all happens. So that could be one of the reason where you might see that you withdraw the thyroxine after some time, right? Fine, great. So this is where you, many a time you patient come, but your patient has come at this level where you can see that T4 is low, the black line, and TSH also is low, the dotted line. So your patient has come exactly at this disequilibrium state. So, right. So if you keep on follow, maybe after a couple of weeks and do, you may need to. So the basic idea is you need not start thyroxine, keep on follow up and see which way they go, right? So that's the way you need to go. And there are studies which mention that post-COVID, they have seen quite a bit of patients of this type, and there are studies on that, right? Okay. What's happening? Okay. It's not moving. So there is some disequilibrium here. So we'll wait for the equilibrium to get settled. Yeah. So I'm sorry for the little bit of a technical problem. Yeah. So this is a lady who is obese. Obviously, the normal trend is whenever they become obese, they blame it on the thyroid. I mean, that's actually a very irrelevant blame, because the common cause for obesity is still a dietary modification which you need, and that's all. Thyroid related illnesses are very, very common, but that is not the real reason for obesity. That can cause, but not to that level, right? But interestingly, this lady has a goiter, so that all the more reason to say that probably hypothyroidism, but clinically euthyroid. And but interestingly, she has a hair loss. I mean, especially women who are obese can have their own problems in terms of their hormonal disbalance and cause hair loss. And the dermatologist has actually put the patient on high dose multivitamin. It's being a practice all across India and globe to give a high dose. Which drug they give? Biotin. I think endocrine PGs, I'll ask them to shut for some time, right? They can shut their whole, shut their shops for come more time, right? Okay, so biotin, right? So, but patient is clinically euthyroid, but you can see a suppressed TSH, right? And T4 is, so what do you want? What do you think? This is, what is this? No, it's not subclinical. It's very, looks very frank, no? Hyper, the TSH is suppressed, T4 is elevated. Doesn't look subclinical, looks like a frank. So shall we start on antithyroid drugs? Come on. Yes, obviously, right? Remember that This is a classical of lab error where because of biotin. It's becoming much more common and common because of the high use of biotin in the community and over the counter. So if the patient is clinically euthyroid, please don't start an antithyroid drug upfront and say, okay, because this much of thyroid functions, you expect the patient to be symptomatic. But here it is absolutely asymptomatic, clinically euthyroid. That's a catch. So if there is clinically euthyroid and a discordant, and remember that some of the assays, the antithyroid antibodies also can cross react and cause high free T4. So that again is actually a discordancy. So the clinically discordant from the biochemical finding. So I'm not going to the detail, but remember that this is basically a lab error, not lab error, lab interference. That's the right word to use. And that's how I mean, you can take a photograph and read it from this nice article later on, right? Okay, fine. So fine, quickly. This is a lady who is having a severe ARDS, patient on ventilator. This is the functions. TSH is, let's say it's low normal, T4 is low, free T4 is low. What is this? Patient is quite sick. So shall we treat? Yes, no, yes, treat with thyroxine. Why the thyroid function is suppressed in this patient? That you need to remember that. Because when the patient is sick, the basal metabolic rate to be as low as possible. So your thyroid hormones and the growth hormone all goes to the bottom of the table, and all the cortisol, stress hormones, cortisol, adrenaline goes higher. So if you are actually starting on thyroxine, your actually mortality increases. There are enough evidence to say that unless the patient is having, where do you treat? Unless the patient is having what problem, you may treat. Pardon? Can it be another differential diagnosis for this patient? Where do you see a similar picture? Central hypothyroidism, exactly. So if you feel that patient is having a clinical features of central hypothyroidism, you can treat hydrocortisone and also thyroxine, otherwise generally not required. So this will be the classical if you do at the heights of patient who is absolutely sick, right? Right. So this is sick euthyroid. Please follow it up because it could be most likely and sick euthyroid where you just need to avoid the test. Remember that when you have a patient with sick euthyroid, when they are recovering, that means post ventilation, you're extubated. If you do a thyroid functions, sometimes there can be in the recovery phase, there can be a slightly high TSH. It's look like a subclinical hypothyroidism. So in a patient who is on a ventilator or post ventilation recovery phase, there should be a clear indication of thyroid function test. That means TSH and T4. If you do it the heights of sickness, you will get a low TSH and low T4. If you're doing it in a recovery phase, maybe the critical care specialist may saying I'm having a difficulty in weaning, then you will do a TSH, but carefully interpret. Unless there is a mixed edema, patient won't come out, right? If the mixed edema, it won't come out. They won't come out unless you give a thyroxine. You can't give a steroids and say, if you give steroids, in fact, the mixed edema worsens and they never comes out unless you add on thyroxine, IV thyroxine especially. So this cannot be a, again, you no need to treat. There are studies which shows that even the TSH goes as high as 30 also. Now we see quite a bit of patients who had a recent ventilator, they goes out, the patient looks little dull because of the post-out recovery, they do a TSH, comes as 14, then need not require treatment. You will keep on follow-up, right? That's very important. Why? Fine. So what exactly is this? Patient has come for routine, you've done a battery of tests, and the TSH comes in that. So the TSH is normal, free T4 is slightly high, T4 is again slightly high. Where do you see this? It's this is high, this is high. Agree? But this is normal. Sorry? Central? That means you mean that TSH is produced more, and that means that TSH is produced, but the T4 is also produced much more from the gland, but it is not going and acting in the periphery. So it's get accumulated there, and okay, suppose if this is both are high, what do you expect? TSH will be suppressed. Let's say low or suppressed. So it is not happening. That means that TSH is continuously producing and TSH. So it is both are producing. One is central hyperthyroidism, extremely rare. Once in 4 years, we see a couple of patients. But we being a referral center, we see a little higher. But otherwise, it's a highly uncommon disease. So that is out, because here it is asymptomatic. Again, there it is symptomatic. They'll have some. So what exactly is this? Is basically a patient is having elevated TSH, or let's say normal TSH. You have don't look at all this. It's little difficult. When you're doing that, look at whether it's a lab error first. Okay, lab error is very, very important, because it can be from another patient. Can possible? Definitely possible, right? Even in our setup also, it's possible. There are events which has happened, but if you're working in some other setup, the tubes may get switched from back and forth. That's the first thing you need to look at. If nothing okay, then it is extreme. You're right, extremely rare where you can see a TSH, but this also is a possible resistance, but uncommon. And does it need treatment with antithyroid drugs? No, you can keep on follow up. In fact, that this is itself is a big discussion. Unless a patient is symptomatic, usually they'll have a high heart rate and etc. You need not treat, you can keep on follow up, right? Okay, fine. I think this you see much common. That's primigravida, 10 weeks gestation, hyperemesis gravidarum. TSH is slightly suppressed. T4 is maybe, let's say, 1.5 times higher normal. T4 is, free T4 is kind of okay. 1.5 kind of okay. So what is this? Normal, abnormal. Is first we'll say, let's say normal or abnormal. If it is normal, then why it is happening? Why it is happening? Patient is having hyperemesis. Hyperemesis, that means is because of HCG. HCG has it's homologous to TSH. So it goes and suppress the TSH and stimulate the T4 to produce T4NS. So it is a physiological response of hyperthyroxemia in pregnancy. Many times there are patients who have been started on propyl thiouracil, or because now it is not freely available, they put on carbimazole, which is antithyroid drug, and then they come back with hypothyroidism. Moreover, what we are indirectly doing is we are harmful. It is harmful to the fetus, because at 10 weeks the brain development depends upon the mother thyroxine, not depend on the fetal thyroid, because it's yet to get developed. So if you are treating with antithyroid drugs, you are actually making the developing fetus mentally differently abled, which is not warranted. So you can actually keep on follow, and unless the patient is symptomatic, which is called gestational thyrotoxicosis, where again we don't need to treat, we just need to keep on follow up required. You can give a beta blocker to a short duration and keep on follow up. Graves' disease is extremely rare. Who's getting diagnosed during pregnancy, it's not common, because those patients, they will have difficulty in conception per se. If they're having a Graves' disease and uncontrolled, they will have a difficulty in their conception. So you would have most likely would have diagnosed prior to pregnancy. So this is a physiological change of hyperthyroxemia due to pregnancy. If you're really looking at, it's a physiological response, right? So no need. So this is basically to understand that there are a lot of pregnancy related hormones which are secreted from the placenta, has a same homologous structure like cortisol, structure like thyroid, like TSH, structure like growth hormone, everything. So you cannot actually treat it. You keep on wait and follow and wait and watch attitude, right? Okay, fine. There's a gentleman who is having a classical feature of vision loss, decreased libido. TSH is, you have done a TSH, it comes as 0.005, and for this response you expect a free T4 to be high. Sorry, this is a typing error, I'm so sorry. T4 supposed to be 2.5, and this is free T4, it's my mistake. So both are thyroid functions are low, so that means it is a central hypothyroidism. When there is central hypothyroidism, you need to look at whether there is anything in the sella, that means pituitary, which probably the reason for the suppressed TSH and reduced free T4 and reduced T4. So this could be a central hypothyroidism, and this gentleman was evaluated and found to have prolactinoma. So prolactinoma can cause panhypopituitarism, where they can have cortisol axis low, pituitary, where the other axis from the pituitary, thyroid hormones, cortisol, and sex steroids. Especially this gentleman has low testosterone. The patient was treated with cabergoline and an MRI which showed a massive sella suprasalama. This is a T2 weighted image, and patient is on cabergoline. And that's altogether a different ballgame, right? Okay. Probably this, you all going to answer this. This gentleman, this lady has atrial fibrillation. Do you use amiodarone nowadays? Common, right? But interestingly, this patient was not on amiodarone. If it is amiodarone, what do you expect? Sorry, what will happen to the thyroid functions in amiodarone? It causes hypothyroidism or it causes hyperthyroidism. It can't cause both the ways. Okay, it can both the ways, depends upon how it acts. So, but interestingly, this patient is not on amiodarone. Now the problem starts. Patient is not on amiodarone, but patient is having a suppressed TSH. Patient is 68-year-old lady. T4 is absolutely point blank normal. T4, free T4 is absolutely normal. So what exactly is this then? The patient is asymptomatic but has a feature of hyperthyroidism. So it is called classical subclinical hyperthyroidism. Can it be recovering from degruent thyroiditis? Still a possibility. Suppose the patient has a angiogram done 3 weeks back. Can it be recovering iodine related thyroiditis? Because contrast has most of the contrast is iodine. So history is very, very important, right? Because could be had a cardiac intervention or cardiac testing, which is interventional testing might have been done. So it could be and contrast induced thyroiditis. So ask for the history, because unless you ask it, you won't. So we might end up treating, right? I'll just skip this because we have some time. We can actually go to the subclinical in more depth. So when you are reading your thyroid functions, it can be a pre-laboratory where patient might have been put on. What is the pre-laboratory errors you can anticipate? Medications predominantly, which can interfere. Could be laboratory where the medication can interfere. Could be post-laboratory where you can have end organs like their thyroid thyroid receptor, basically resistance of thyroid, or this all are extremely rare. Remember that this is much common than what we anticipate, because heterophil antibodies of various reasons are possible. Don't worry about this FDH, leave of that. Biotin is becoming increasingly popular. Remember that we are finding quite a bit recently, and the treatment is you stop biotin and recheck after 1 week. In fact, within a week you will get a normal function, because it's not a functional problem, it's a laboratory error, right? And this is very important, because most of the time you see a hypothyroid patient, you start on thyroxine, classical primary hypothyroid, start on thyroxine. How long do you wait to see a definitive improvement in the TSH? At least 6 weeks. Why the 6 weeks? Why the magic number? Why not 5 weeks? Why not 7 weeks? Why the magic number? Because you need a 6 half-life to clear something, right? You have anything, let's say iodine, not iodine, any radioactive material, or you need a 6 half-life to get vanish, right? So you don't need a 6 half-life to have a TSH to become normal. Okay, and pregnancy, watch for it, okay, because it's very common, and people basically quite a bit of patients put on propyl thyroidism, right? So this is just to take a photograph and keep it. I'm not going to detail where you might be ending if you do a TSH alone and interpret. Because let's say we'll take only one non-thyroid illness. You put TSH alone, it be 0.2. You may be so look for clinical finding and do a T4 FT4. That is absolutely a clinical diagnosis. All these are clinical diagnosis where you probably need to aware of this. If it is warranted, you need to. This is, I'm going to talk a little bit here, because if you are starting a patient on antithyroid drugs, and let's say carbimazole, right? You are starting because patient is having absolutely Graves' disease, no second diagnosis. You're starting on carbimazole. Please don't repeat a TSH after 6 weeks or 12 weeks or 6 months, because the thyroid TSH axis take a longer duration to go back to normal. So if you are starting on carbimazole or propylthyrosol, you have to actually follow up with the T4 levels. And in our setup, the T4 comes with free T4. If you have a T3, better not to do that, because it was a very notorious test, which are very high coefficient of variation where it fluctuates to a greater degree. So in patients with Graves' disease, you need to be aware that TSH takes longer time because of the long duration of suppression. But subclinical, degrowth thyroiditis, it's a short duration suppression. So the TSH comes back to a normal much faster. But if you are having a Graves, it's actually a longer duration of symptom. So please don't do a rely on TSH. You will be seeing TSH suppressed only for at least 6 to 9 months to even 12 months. Then you will be end up in a serious trouble, right? Okay, fine. This is, I found it, this slide very interesting, because it puts everything into the picture, where you can see a discordance of thing which much more that even dopamine can cause, steroids can cause, but I'm not going into the detail of this. But remember that you might get a patient where heparin, put on heparin, and you can see, where is it? Right, heparin is here. You can see this particular discordancy. So, but remember that, watch for it, because thyroid function is sometimes cannot be straightforward. We being a referral center, biases do happen. So you might get one of this patient as well, right? And you can take a photograph and keep it. I won't go to the detail, because where you might interpret as a wrong interpretation, and the correct interpretation could be one of that. It's whatever I discussed is put here. You can go back and look at and read that later, because time. Okay. The take home message is clinical examination alone and interpret the thyroid functions. Don't interpret the thyroid function just because you got one TSH T4 available in our center or wherever you are working. Don't look at that just because it can be totally an asymptomatic normal people also, where you might end up putting adding on an antithyroid drug, or could be an thyroxine, which is really not warranted, right? So treatment varies, right? So I will just probably take a little more time here. And so interestingly, I found this very beautiful slide, where please, the guidelines itself starts like this: please don't do any tests unnecessarily. Please don't do a thyroid ultrasound unnecessarily, right? Because it is going to give more trouble than actually a good reason to do that. So this is the bottom line. So very strong statement. So test should be depends upon your clinical description, and also test to be ordered, especially the ultrasound. Though it is a non-invasive test, you are going to get more confusion after that, right? Okay. Okay, fine. There's a lady who is 63-year-old postmenopausal lady, and long-standing hypertension, well controlled. She's having palpitation, but other toxicity like weight loss or tremors not there, and patient has no thyromegaly. Patient is having atrial fibrillation with fast ventricular rate. The echo is showing no structural abnormality. Very classical, probably atrial fibrillation due to long-standing uncontrolled hypertension, and there is no structural abnormality in the echo. And because patient has palpitation, probably that could be because of atrial fibrillation. Yes, but you are part of the workup. You've done thyroid functions, suppress T4, total T4 is slightly high normal, T4 is normal. So what exactly is this? What are the differential diagnoses you will consider here? I think we need to spend some more time here to discuss further here. I mean, then it makes a little more interesting. Is this Graves? Yes or no? No? Yeah, because its patient was classically asymptomatic except for palpitation, which could be. Can it be degrowth thyroiditis recovering? Could be, but we don't know. But there is no weight loss, nothing. There is no fever, nothing. Can it be secure thyroid? No, not really. Can it be amiodarone induced? Can be, but patient has no history of amiodarone intake in the past. It could. Can it be a iodine related thyroiditis where could be, but there is no history. So the only, this is clinically asymptomatic except for palpitation, but the thyroid functions are kind of borderline. So this is actually a classical, you will see in your patient where there is, you rule out everything where can cause suppressed TSH and slightly high T4 or let's say free T4. It's classically, this is how the subclinical is basically your diagnosis of exclusion. You exclude everything in the world and say that it's nothing, probably no lab error, nothing. Then you actually come up with a diagnosis called subclinical hyperthyroidism. So basically, this is one article from Nenny James which says that TSH less than normal or suppressed to a rock bottom like 0.0001 also. And but remember that this is the commonest one, excessive thyroid hormone therapy in patients with hypothyroidism. Okay, most patients when they go to the pharmacy, they inadvertently taking that. A lot of patients, so ask for the history, right? Endogenous overproduction of thyroid hormones, possibly, or maybe malignancy where patient had malignancy. That is where it's also need to remember that in patient with papillary carcinoma of thyroid, they give a higher dose of thyroxine to keep the TSH suppressed because those are TSH dependent tumors. So in those patients, please don't reduce the thyroxine and make them euthyroid because that means you are doing more harm, right? So TSH will be those. So these three has to be thought in mind before thinking of a subclinical hypo as well. This is very common because patient might have gone elsewhere and you might not have seen flip the pages, the TSH may be 6, somebody would have started on 100 microgram thyroxine, which probably not clinically indicated. And endogenous, this is could be an evolving graves also, but that's very remote. And this is very important because many times we tend to reduce the thyroxine and keep them euthyroid, but by and large, to certain period of time, patients with papillary carcinoma, especially because why I'm telling papillary is the commonest variety of thyroid cancer, right? So, oops, what's that? Yeah. Oh, interesting. Okay, so when you think of endogenous, so you're thinking of endogenous. This all the causes, same thing. I'm just putting it to understand that, and you can see that there are sometimes when a patient is on steroid and dopamine also, you can see more this kind of feature. But I'll just skip to and go to the. So the differentiation point is always a clinical. A clinical diagnosis can distinguish, provided you rule out others. And remember that this again is most commonly you see patient with psychiatric illness, you see this kind of picture, but that again does not need therapy. So I'm talking in the line of no treatment for anything. So if you're before putting an antithyroid drug, think twice, thrice, and rule out all the causes of whatever you know in the world, right? And now the question is, when do you treat? I want to treat, right? Because now you say that this is not from the pituitary where there is no subclinical, no central hypothyroidism, there is no amiodarone intake, there is no history, nothing to suggest the patient was on, let's say, multivitamin which contains high domain, superhuman dose of supraphysiological dose of biotin. Then you can absolutely diagnose that it is subclinical hyperthyroidism, but you need to treat, right? Sometimes, not always. Predominantly, it's a physician discretion. Remember that the physician should, yes or no, depends upon the patient to patient, right? By and large, if it is this, you can almost always keep on following. In otherwise, if the patient is symptomatic, and rule out others, the first line in this guideline is talks about rule out other causes And if the patient has a heart disease where there is a structural heart disease or atrial fibrillation, hyperthyroid symptom where you can see a suppressed TSH with T4, free T4 normal, osteoporosis, have to especially if a patient has 65, or leave of this last because that again fits into the osteoporosis. Right now the question is, in this lady 63, what are the options? Patient is having, this patient is 63-year-old, patient is asymptomatic, so you can probably keep on follow. Patient is having atrial fibrillation, so cardiac disease, you can consider treatment, not always. You can keep on follow up also because the TSH was 0.1, right? So you have to have your clinical judgment and treat, because this is one of the area where there is no clear guidelines to say you have to treat. They always say consider treatment or treat, but heart disease and osteoporosis is the strongest indicator for treatment if there is suppressed TSH and T4 are normal and patient is less than 65. More than 65, most of the time it talks about treatment, but again this is extremely uncommon. The reason I'll tell you, most of the time there will be some medication interference, there may be thyroxine, excess thyroxine intake. Most common is the other causes, like you will patient may be on a patient may had as degrown thyroiditis and recovering. All these are much common, but this is absolutely a biochemical diagnosis. So when you are having a biochemical diagnosis, if you want to treat, clinical judgment is the only thing. So this is your decision to treat or not to treat. But there are events where if there is, sorry. So you are the best person to treat or not to treat, because if you are going to start an antithyroid medication, the follow-up is going to be really tight, because this kind of patient suddenly go to a hypothyroid state and then come back. So if you are treating, you need to have 100% confidence to treat. By and large, this is uncommon. The reason I'm saying uncommon, you see those TSH and T4, FT4, but that reason for is uncommon. That means it's a diagnosis of exclusion, right? Suppose if you have a doubt, then it is better to do an uptake scan and see whether there is an increased uptake. But it will be the ideal way to go. But remember that most of the time you won't be having those facility to do. But these are the causes for thyrotoxicosis with the low uptake or near absent uptake, where this does not need any treatment. You can actually keep on follow up. Suppose the same patient, postmenopausal lady, you have the luxury to do a uptake scan because you are absolutely sure that that is subclinical hyperthyroidism. The best way to go is this way, if you have a facility. Otherwise you have your own clinical discretion to do and start an antithyroid or not, right? Okay, fine. Those who have a high uptake is top in the list will be almost Graves, almost always, and toxic adenoma, MNG, trophoblastic, these are all uncommon, but the top three are the common ones which we see, all we'll see in our regular practice, right? So when it comes to antithyroid drugs, we have carbimazole, methimazole, propyltyrosol, and lithium. Lithium is a short probably medication where you can give, especially in a patient. Suppose you have a patient with hyperthyroid where there is an absolutely low level of counts, where you can start on carbimazole or methimazole or propyltyrosol. Or you may be having a patient who is having a liver failure, where you can't start on medications which metabolize via liver, which especially carbimazole and propyltyrosol, you can't give. Then you can have a bridge therapy with lithium. The problem with lithium is it's a narrow therapeutic window. So if you ideally need to give 300 mg at least BD or 200 mg BD to, okay? So they tend to have a side effects of lithium in terms of tremors, and on top of having patient hyperthyroidism, it worsens. So it can be having a bridge for an final iodine therapy or a thyroidectomy. You can bridge with that. But remember that you can use it in patients who have an absolutely contraindication for that drug. Cholestyramine is there, but again, that again is a bridge, but that's not commonly easily available or not commonly used, because you have to give a whopping dose of that cholestyramine. Okay, fine. So you have three treatment, radioiodine. You all know that where you give iodine and ablate and completely burn the thyroid, right? And or you can give antithyroid drug. The antithyroid drug has to be given long term, or maybe an upfront thyroidectomy where there is a large goiter which may not amend with radioiodine, or antithyroid drug is not the choice because it's huge. It doesn't make any sense to continue for lifelong, because remember that most of the antithyroid drug has to be given for 12 to 18 months and then taper and stop, right? I'll give a simple, probably who are beginners to think of. If you have an FTC, FT4, free T4 levels, you can actually probably easy to start on antithyroid drugs. I mean, it's a, let's say it's a some kind of a rule of thumb, right? So if you find a FT4 more than 6, you can start with 6 tablets of 5 mg of carbimazole. If you have a FT4 of 4, let's say 20, I'm sorry, FT4 of 5, you can start with 5 mg of carbimazole, 4, 3, 3 and 2. It's not a hard and fast rule, but people who are really want to clinically want to write, okay, I want to at least follow a little bit of him, you can do that, but there is no books which really talks about it, but it's probably a real easy way to start on. And you may be 2, you don't need to start higher dose. Remember that why are we starting with you can even start with little higher dose also. The real reason is that we have to achieve the intrathyroidal carbimazole levels, not the blood carbimazole level or the blood PTU levels. So that is why you can, even at 2, you can start with 6 tablets of 5 mg and taper it down to 10 mg or 5 mg very faster depending upon the clinical finding. That is one. Second thing is, all these drugs are long acting. It acts for 16 to 24 hours, and even the intrathyroidal half-life. So please don't need to give it multiple doses. For complaints, you can actually make the patient take 10 mg once daily, or don't start 10 mg PD. Doesn't make any sense, because it's all the half-life is much longer, and if you are giving once daily dose, the complaints improve. If the patient misses in the morning, they can always take in the evening, because compliance is much higher if the patient takes once daily dose. So don't need to give a higher dose and splitted dose. I mean, let's say if your patient is having a free T4 levels of, let's say 6, you want to start on 30 mg, that means 5 mg 6 tablets. Don't give 10 mg TDS, doesn't make any difference, because it's a long acting drug. You can so now, what is the diagnosis? Very straightforward, right? Patient is symptoms for 3 months, diabetes and asthma, just palpable goiter, taste is suppressed, high. This is the feature. This will be how the classical Graves comes into your, I mean, you no need to go around and catch the diagnosis. Look at the face and diagnose. They comes with the proptosis, could be having a dermopathy, could be having a acropachia, or could be one nodular dermopathy in the shin of tibia, right? That's called pretibial myxedema. Though it's not myxedema, it's called pretibial myxedema. So this could be a classical feature where they walk with diagnosis. You don't need to get a different diagnosis on this patient. Or maybe they walk with a large goiter with tremors and palpitation. So if these two are there, most of the diagnosis is Graves' disease or Hashimoto's. They are both hand in hand, because both has hyperthyroid feature. The one major difference is Hashimoto's thyroiditis, they go to a euthyroid and hypothyroid and they die. Graves' disease, they continue to secrete and then they die when, I mean, the thyroid gland die. That's called Randall's. But once they die, the patient cardiac functions would have gone down, patient's muscle mass would have gone down, patient will have the other features in the body in terms of their hyperthyroid side effect, the consequences of hyperthyroidism. So the gland, if there is hyperthyroid because of Graves, it kills the patient. By the time they'll come with a cardiac failure, could be thyroid storm, could be an emaciated, sick patient. But Hashimoto thyroiditis, if they have long, they will go to a euthyroid and then hypothyroid. They die. The Graves doesn't do that. The Graves disease do happen, but by the time if you don't treat, patient will have a major complication of Graves disease, right? Okay, fine. So if you have a symptoms, make sure that you do a TSH level. Ideally, if you go to any Western countries, they'll do an uptake scan and diagnose and treat. So if you have a Graves disease where you feel that you can ablate, call the nuclear medicine and they will do the uptake scan, ablate. But remember that those patients has to come back and see you. Why? Because our final treatment is actually the make them hypothyroid. All the radioiodine ablation, we are trying to make it hypothyroid. But interestingly, in our setup, because of our policy, we try to make them euthyroid, but that is not common. But universally, hypothyroidism is the final endpoint for hyperthyroid, especially Graves, where you give a radioiodine. But in our setup, it's a little different. That's why we give a slightly lower dose of radioiodine therapy in the form of 5 millicurie. But in outside CMC, especially in other part of the country and the world, they give 15 millicurie and destroy the thyroid gland absolutely. So they become hypothyroid. Remember that those patients you can easily treat with thyroxine and follow, because you treat with thyroxine and then they become euthyroid and they can continue and so on. Suppose if you don't have that facility, then you probably, let's say you started on say 30 mg of carbimazole. Let's say you're started on 30 mg of carbimazole. When do you follow up the patient next? And how do you follow? You give at least 6 weeks. Again, your whole theory of clearing of the thyroid. So ask them to come after 6 weeks. What do you want to do at that time? Exactly, ideally you need to do a T4 and FT4. If you do a TSH, it will be suppressed. 6 weeks. Book says 4 weeks, but 4 weeks is too shorter duration. Suppose the patient has come at 4 weeks, or let's say 6 weeks. The free T4 is 2.1. T4 is, let's say, 16. Patient is on 30 mg of carbimazole. What do you do? This is, I didn't put it in the slide. I want to see what exactly you think. It's cat on the wall. The best is look for clinical signs. Patient ask them to step on the weighing machine and see whether the weight is improving. Check for the pulse. If the pulse rate is normal, wean off the propranolol, or if the patient is having asthma, like this patient, you probably put on diltiazem or verapamil, or in extreme cases, you can put any other rate controllers you want, maybe ranolazine or ivabradine, all reserved drugs. But by and large, usually the traditional medications are propranolol, which has a non-selective beta blocker, ideally, but it has its own problem of having the asthma getting exacerbated, or COPD or reactive airway getting exacerbated. So you can use don't use metoprolol or atenolol, which is it is not select. It's all selective ones by and large. Carvedilol. So you can't use all those. So you can go to an rate limiting calcium channel blockers. Especially you can give a diltiazem or verapamil. But verapamil is much more rate control. You all know that. So we can, but very rare we use other drugs, but it's not common. Let's not go into those medications. Now you can wean off and stop. Then the patient, when do you ask the patient to come? You ask him to ask him to come after 1 more 6 weeks. Then you will see that T4 is, let's say, 10. FT4 has come to 1.2. Patient is on carbimazole, 30 mg. What do you do? TSH you won't do because TSH will be suppressed. Now it's 3 months now. Patient has had 3 months has come on 30 mg. T4 is normalized. FT4, 3T4 is normalized. If you have a T4 alone done in your setup, again T4. Don't do TSH at least 6 months to 9 months. Right? Now what do you do? You start reducing the carbimazole, because our achievement is for intrathyroidal carbimazole. That means there is enough intrathyroidal carbimazole has happened so that the thyroid hormones are gone down. So taper, let's say from 32, you can make it 20, nothing will happen. And then you can ask them to come after 2 to 3 months. Let's say patient has come after 2 to 3 months. Free T4 is again 10. It will happen. You start working on it, it will happen. Because after, let's say after 3 months, that means 6 months of the initial diagnosis, patient is coming back. Free T4 is 0.9. T4 is again 10. This is what will the pattern. Unless the patient is having a large goiter, this won't happen. There is a small goiter, Graves, classically, this will happen. Again, don't do it to TSH. Do a free T4 and T4. Then the patient is probably on 20 mg. Then you can taper it to 10. Then after 3 months, you again. So taper it down. By the end of 9 months, the patient's pituitary thyroid axis will start recovering. So those time you start doing a TSH. 9 months you just do it. You will say from your 0.0001, it will come to 0.1. That means that the axis is not recovered, but there is a sign of recovery. So when you see a sign of recovery, you can taper it down to 5 mg and keep a sustained dose of 5 mg. You can ask to come up to 3 to 6 months also at that point. That means you feel that the thyroid axis has started recovering. So once it started recovering, you give the minimal dose, 5 mg, and ask them to come to 5 to 6 months or 3 to 6 months. Patient has come back after that, then you see a 0.1 again. And free T for a normal patient's gain weight, patient looks absolutely fine, pulse rates are normal, then you continue. Or you can, if you're little more confident, you can make it to 2.5. That depends upon your confidence, but 5 mg OD is itself is fine because we are trying to maintain the intrathyroidal carbimazole dose. By 12 to 18 months, you do a TSH. If it is recovered, let's say it's become 1.1 or 2.1, that means it's come up to above the level of the really normal. You stop it and check after 2 months the T4 and TSH, free T4 if it is possible. So by 12 to 18 months, you can actually stop the thyroid medication in almost 70 to 80% of patients. In that 70 to 80% of patients, few of the patients can have a recurrence, right? I didn't speak about the TSH receptor antibody because it's a little expensive and it's not freely available. Those you can reserve for where you have a clinical diagnosis was query, where you're not very sure it is degrowths or which is could be in Graves, you can do that. Otherwise, by and large, I'm not a fan of TSH receptor antibody because it has both inhibiting and activating hormones actually. So TSH receptor antibody is a good marker for recovery, but reserve that for a diagnostic purpose and recovery, not for the prognostic purpose as such in the current context, unless we have a thyroid TSH stimulating in, immunoglobulin, TSI, which is probably the strongest one, which is not really available in our setup, what we don't know. So by 12 to 18 months, start doing the TSH and look for recovery, then you can stop, right? Understand? Because I took quite a bit of a time to explain this because I want to make everybody clear that don't do a TSH in the initial period, at least 6 months to 9 months to 1 year, then start doing a TSH and T4, FT4, then look for recovery and then stop the medication. Remember that at least after stopping, you have to make the patient come at least 3 to 6 months review and also educate the patient if there is hyperthyroid system, they have to come because up to 50 to 60% patients still can recur, some of the patients. Okay, so those patients you need to be educate also to make sure that they understand the symptoms and come. So you need to always talk to the patient and make them aware that hyperthyroidism can recur, especially when patients on antithyroid. Other words, in radioiodine patient, that means who are given radioiodine uptake and ablation, they by and large around 90% of patients go to hypothyroid phase and you treat. That is why most of the physicians do go for upfront radioiodine because you no need to have this tedious repeated follow-up and repeated dose adjustment. It involves cost, and compared to the cost for the radioiodine and the repeated follow-up, the radioiodine probably much easier, though it is a bulk amount. Got the point? Right. So that's how you need to follow up. Even if it is subclinical hyperthyroidism, again, you start with 5 mg once daily of carbimazole because the FT4 is 1. So you frequently follow. That again, the TSH takes a longer duration. But there, usually by 9 months, they recover, not like 12 months to 18 months. So subclinical hyperthyroidism, you need to have the same follow-up, but the lowest medication you can start and taper and stop. I'll stop at this. The same thing I put it in the slide, like just to, okay, fine. So any questions? I think I'm on time. Yeah, great. Right? Any questions? I know this is an exhaustive talk, but want to make sure that thyroid functions are easy to interpret, provided you keep a close watch on it, and follow-up is very, very important. Yeah. Thank you so much. If there is, yeah, please. Yes, gentlemen. Microgram is more common. 25, 50, 75 is especially in patients who is having a cardiac disease. Pregnancy, you can hit hard and come down, no harm, nothing will happen. Because if the patient, let's say, I'll say patient is coming to 30 microgram or 30 milli international units of TSH. I give upfront 150 and bring it down. Because if you make it little hyperthyroid, nothing will happen. But if I'm making them hypothyroid for a long time, especially in 10 weeks old pregnancy, the whole thyroid of the fetus depends upon the thyroxine. And moreover, the thyroxine levels get destroyed in the placenta as well. So whatever entering also will be low. So you need to can go hit hard. Pregnancy, don't worry, nothing will happen. Even if you become little hyperthyroid, after 3 weeks you can taper it down, it will become normal. By and large, it's all clinicians' discretion only, especially hypothyroid. You can start with 50, nobody will penalize you. If you start with 100, that's okay. Even if you feel that you can step up 25 to 50, 75, no harm, nothing will happen. Treatment is right. You can go with either way. Right. Yeah, gentlemen. Yes. Okay. First, look at the weight. If there is hyperthyroid symptom or not. If it is hyperthyroid symptom, I'll just taper it to 50 or 75. If the patient is asymptomatic, go slow, 25 or 12.5. Yeah, 100. That's right. Your clinical discretion, it's very, very important. Look at patient is having high. Look at the palms, whether there is any moist in the palms. Look at very subtle tremors. Put a paper and see whether it tremors. Look at the weight and see whether any major weight loss. All of us looks very small, but look at this. And if it's hyperthyroid symptoms are there, you don't have a free T4, that means it's hyperthyroid only. Then you can even bring it out to 50. But you looking at a patient where you started with 100 and the patient is asymptomatic, then you can go slow, 12.5. But if there is a pregnancy, I won't do unless there is symptomatic. If the patient is cardiac, probably I'll do much faster, probably 25 or 50. No harm. It's not no hard and fast rule that how much. It looks upon clinical, and taper. I go that way. In symptomatic, drastic low dose. Asymptomatic, go slow. Even 12.5 or 25. Clinical, go to 50 or 50%. Am I clear? Clinical, go with the clinical. It will definitely, you will give it. Because why it is suppressed? There is more thyroid hormones, it would be suppressed, or the patient would have taken 3 tablets previous day, it would have suppressed. For last 4 days, it would have suppressed extra tablet. The patient is symptomatic, it's up. But if there is no symptomatic, go slow. And that's a mantra I will take. Right? Okay. Yes, lady. Wow. Pediatric population, they have to use some Vijayalakshmi Bhatia. It's the easiest Indian book where they can follow. They really want to follow. There is another book called, what's that? It's called with yes, Springer. What's that? Sperling. Yeah, Sperling. If they really want to excel in their diagnosis, I mean, excel in the way they understand, Springer, right? Sperling. Yeah, that's the one. Right. Otherwise, Vijayalakshmi Bhatia, it's much more easy to understand. And right, any more questions? Okay, if there is no questions, thanks everyone for joining online, offline, and asking questions, because asking questions is a big way to learn for me as well. And if you don't ask questions, your gray matters will atrophy faster. And so please do ask questions wherever you are, because we don't ask questions, we are at this level. Even the government changes, we ask questions, right? So do ask questions wherever you are. Right. Thank you so much and have a great week ahead. Oh, sorry, weekend, right? Weekend.